All right, everyone. Thank you so much for being here and welcome to the 2026 AI Cohort Series brought to you by the California Telehealth Resource Center. We're so glad you can join us for today's session titled AI Scribes in Action, Lessons from a Practicing Physician. I'm Amelia Ochoa Ruiz, Manager and Principal Investigator for CTRC, and I'll be your moderator for this session. All right, our disclaimer is this session is purely for informational purposes. CTRC has no relevant financial interest or arrangement with any organization related to commercial products or services discussed during today's session. Before we begin, I'd like to go over a few tips to help you navigate today's session. You can use Microsoft Teams functions to ask questions, post comments, and connect with fellow attendees. And interact during the session. This session is being recorded and will be posted to our CTRC YouTube channel. And if you happen to encounter any technical issues, please reach out to a member of the CTRC team on the platform or contact us at keltrc@ochin.org. At the end of the session, we will hold office hours hosted by our partners at TTAC. They are the National Telehealth Technology Assessment and Resource Center. And the work that we do here at CTRC would not be possible without funding and support from our from the Health Resources and Services Administration's Office for the Advancement of Telehealth. That's HRSA, and the California State Office of Rural Health, part of the Department of Health Care Access and Information, HCAI. So I'd like to introduce our guest speaker, Dr. Gigi Magan. Dr. Gigi Magan is a bilingual board-certified family physician in Northern California. She practices at a federally qualified health center where she is part of a language concordant team caring for predominantly Spanish-speaking patients in their own language. She led a study across 4 family medicine residency programs of how resident physicians and faculty experienced an ambient AI scribe before and after it arrived in their clinics. The study earned a 2025 National Award for Resident Research, given jointly by the Association of Family Medicine Residency Directors and the North American Primary Care Research Group. A manuscript is in preparation. She taught AI and digital health at the UC Riverside School of Medicine, serves on the advisory board of the CTRC, and is president-elect of the Sonoma Mendocino Lake County Medical Association. She writes weekly about AI, equity, and primary care at drgigimagan.substack.com. And with that, Dr. Magan, the floor is yours.
Well, thank you so much for having me today. I'm very honored. And maybe let's give folks maybe one more minute for everyone to trickle in.
Sounds good.
Just a few more seconds. It seems like we're having more people join in. Great. Okay. I think in the interest of time, maybe we should get started, actually. All right. So today we're going to be talking about ambient AI scribes in clinical practice, what the evidence shows, consent, and equity. And this comes from research and also my own clinical practice because I do use one of these tools every day. And let's talk about it. So before we continue, I don't have any financial disclosures, and any tools mentioned in this presentation is for educational purposes. Similarly, anything related to legal, some of the laws and legislations are also for educational purposes. And this evidence is current as of last month, as of July of 2026. And any information about patients it's a composite and de-identified. Next slide, please. So if you remember nothing else, remember 3 things. that the documentation and the burnout data is very real. However, the risks are uneven. Uh, the tool that may work really well in a suburban clinical practice may not work super well in the safety net because of differences in languages or accents, and also due to code switching. Maybe they start in English or Spanish or just different languages or using an interpreter. So the risk is not evenly distributed, but it is fixable. I do think that if we learn how to use these tools very well, we focus on consent, a pause habit, and contract terms, all those things are still within our control. And those are things that we'll be talking about today. So this is what I hope that we're going to be covering by the end of the hour. Explain how these tools work, some of the evidence in the literature, also talking about consent workflows, and also an equity lens. And before we continue, I would love to learn out of those folks in the room, how many are using an ambient AI scribe at the moment, or how many are piloting one at your institution? I see 2 hands, 3, 5. And Amelia, if you can keep track on how many hands are up.
Yeah, it looks about half of those right now that have responded are of those on the call have used an ambient scribe.
Wonderful. And I'm curious, out of those, how many have workflow consent, a written one set in place? See 6, 7.
About half of those who had their hand raised.
Ah, okay. We're going to be talking a little bit more about that. So let's keep going. So this is a roadmap for the presentation. So a little bit of the background, the documentation crisis. A lot of us are familiar with that. How these tools work, what the evidence shows, a little bit of patient safety, guidance governance, and some practical tips. Next slide, please. So let's start with that documentation crisis. And this is actually very well understood in the literature. Next slide, please. Okay, so most of you probably have heard the study by Sinsky et al., the time motion study from 2016. And really what that one showed was that for every 1 hour of direct patient care, we spend about 2 hours in the EHR or electronic health record. But this is actually a little bit misquoted because this study, what it looked at was 57 physicians, and it looked at how much time they were spending per task and also desk work. So it was EHR time and desk work. And these were actually high performing practices. So if anything, this was on the optimistic side. And then there were a couple other studies by Arndt et al. From 2017 that found that most clinicians, most folks are spending about an hour to an hour and a half in after hour documentation, or what we call pajama time. And then there were a couple other studies that found that it was about 1.4 hours. So the time difference actually varies a little bit, but they all kind of move in that direction of the administration burden and documentation. And this is what these tools were hoping to solve. Next slide, please. Okay, so what has happened? So that was pre-AI boom. So now the American Medical Association has done a survey in the last 3 years. So from 2023, 24, 26, and we see that the adoption of AI has more than doubled from 38 to now 81% as of this year. And the interesting part was that the percentage of clinicians that said that it really helped with patient care actually increased from 65% to 76%. And about 40% of them were equally excited but concerned about AI. And 90% of those really wanted really wanted to have safety validation and clear liability before they can trust it. So most of us want to use it, but we want guardrails. Next slide. So how do these work? Next slide. So this is basically the workflow, right? So first you have the encounter audio, either a microphone or a cell phone in the room that is capturing the recording. Then that gets turned into speech to text recognition. So similarly to the voice to text on your phone, for instance. Now that gets sent to a large language model similar to like ChatGPT or in that family that takes the draft and then it turns it into a SOAP node. So subjective, objective, assessment, and plan format. Then the clinician needs to review it thoroughly. And then what you sign is what stays on the chart. And so that's where it's really important to pay attention to the consent. Because the first three steps are actually happening outside of the clinic on the vendor's cloud. And then the last piece is what we're responsible for. And this is not really dictation. It's not your traditional word by word that gets put into the chart. So it's actually using generative ambient AI. So some things some people ask me questions about why did I write something that I never said? Because it's not transcribing word by word. It's actually trying to figure out the next best word. So if we do, for instance, a knee exam and we don't say it out loud, it may just type that it was a normal exam when maybe it wasn't. And that's where these errors feel so believable because they look just right. And that's when proofreading is really, really important. And every stage has a failure mode. The first part could be that the speech recognition may not hear things very well when it's a different accent, and that's an equity problem. Then it may drop something like a review of systems, and that is a safety problem. We may miss it on reviews. If we're skimming really quickly, that would be a human factors problem. And then the audio sits on a server somewhere in the cloud. That could be a legal problem. So that's why the vendor owns the first three steps and we are in the fourth. Now, there is a step 5, and this is what happens to the recorded transcripts. And that's why we have lawsuits today. So why do we love them anyway? And it's mostly because of the cognitive load. If you think about it, when we're in an encounter with a patient, we are listening, we're processing the information, we're keeping track of all the details, we're typing, we're going through our differentials, we're thinking about right the management and then the counseling. And now, if you're doing this in a different language, it adds even more to the cognitive load. So this is why these tools are helpful. And some people really love it because it brings back the attention to the patient. And some patients really enjoy it as well. But there's more to the story. And what does the evidence show? So right now, the evidence is still pretty new. We don't have a whole lot of information. There is a one randomized controlled trial, and we're going to talk about that. There are a few QI studies, and most of these studies have happened in academic settings, not in small clinics, and certainly not in the safety net. So a little bit more about the RCT. So this is a randomized control trial that was at UCLA, and it looked at 238 physicians and used two different tools or usual care. And really the point is not which tool was better, because they didn't really perform the same. And one tool actually, it decreased time by about 10%, and that was significant. But another tool only decreased it by 1.7, and it wasn't really significant. But they did mention that the task load and burnout improved. So that's the question. So is it we need to pay attention in what setting, what EHR, and which tool, because they all kind of vary depending on the setting. Now, the biggest study was by Rottenstein et al. Earlier this year, and it looked at about 8,500 clinicians. And this was across 5 academic centers and compared against people who adopted and people that didn't. And the gains were real but modest. It really showed 13 fewer minutes of EHR time per 8 patient hours and about a half a visit more per week. But really, the pajama time did not budge. It didn't really change. So that's why we need to pay attention on, do we add more visits? What about wellness if that's not really changing? So this is something to think about. Now, about the burnout signal. It's really early and partially vendor adjacent. A study by Olson et al. Looked at 263 clinicians, 6 systems in about 30 days. Burnout did drop by about 13 points, and that is huge. That's helpful. But it was 30 days later. A lot of these were self-reported. Some of them were funded by the sites, and 2 of the authors worked for the vendor. So we just need to take it with a grain of salt. And I think that there is more research that needs to come out. Now, looking at deployment at scale, the Permanente Medical Group did one of the largest published studies, and they looked about 300,000 encounters, 2.58 million encounters in 1 year, and they found that it saved about 15,791 hours saved in 1 year. So we know that this can work at scale. One caveat, though, is that it didn't really have a control group, but it's still very promising. Now, what about node quality? There were 2 studies that looked at this. Palm et al. From 2015 did an audit, and the AI nodes scored almost as high as physician nodes for this study. But the hallucination rate showed about 31% of them versus 20% in human nodes. So the AI generated had a higher percentage. Now, on the second one, by Reddy and all that came out earlier this year, um, the blinded reviewers preferred the human notes across all 10 quality domains. And as one physician put it was great storytelling, but not so great at synthesizing the clinical notes. So it's good enough to help, but not enough to just trust it without reviewing. Now, what are the things that we don't know? So this is where more research needs to come. So no trial has actually measured patient outcomes. It's all minutes and burnout scores. And then 2, we have no controlled data past a few months. Most of them is about 1 month, maybe 3 months, but nothing really beyond that. So we don't know the long-term effects. And then 3, only one small trial compared 2 different platforms. And we know that there's several different MBNAI scribe vendors out there. So, and the other really important thing is to understand the setting. Is it a safety net or is it academic center? Because the patient population is not going to be the same. A little bit more about patient safety. What evidence shows. So there are 4 ways in which an AI node can go wrong. And we talked a little bit already about them. So first, it can be a hallucination, is content that maybe was never said, that is on the note, like maybe a normal exam or a word or something that wasn't really said, but was on the note. And under your signature, that can be a false entry. Also, it can be an omission, when something just quietly gets dropped and you don't notice. And that can be really sneaky because we can catch the hallucination because we see it there, but we may not see something that was dropped unless we're really paying attention. Now, misattribution is when a patient's word ends up as yours, or misinterpretation is the right word but the wrong meaning. And the best audit, we have found hallucinated content in about 30% of the notes. Now, something that I've seen on my practice, like these are actual things that have happened. For instance, I had an encounter with a patient with a UTI, and we said macrobid, but then on the note was migrabid, which is a medication that doesn't really exist. Now, something that happened to one of my colleagues was they tend to do a lot of diabetes counseling, and there were the phantom tortillas. Basically, they didn't really talk about tortillas. However, that was written on the note because it was the tool that predicted that that was going to be most likely to be part of that sentence or that conversation. Now, that also could be a stereotype. And then three, a patient could point where it hurts, but the tool may not know where you're pointing at. So that's why saying it out loud can be really important. And then four, it could try, sometimes the note looks so much cleaner and polished, especially for a very complex medical encounter. Now, the signature is the safety system that we currently have, because right now we get a draft and then it's our responsibility to look through it very carefully and make sure that we're reviewing and either adding or deleting things. And some of that work, it's real work. It may be unpaid or invisible. And if we're running behind or we have lots of patients in clinic, we may want to just skim and we may miss some information, right? And that is the automation bias, and that's part of human factors. So the other piece that can happen is when it comes to trainees. And this is part of a bigger conversation in which there is a de-skilling. And what if you're typing the note, then you're going through sort of the illness script and you're building your differential and your cognitive skills. And if the note is just doing that for trainees, and are we de-skilling? But this is part of a bigger conversation. Um, and so what I do in my clinical practice is one, make sure that you're choosing the right encounter, that you're not recording in the wrong patient's chart. Capture by narrating out loud, for instance, oh, it's the left shoulder or it's the right ear. So saying things out loud, and then make sure that we're checking the exam, the assessment, and plan, because those are where a lot of the errors can happen. So more documentation and less management. And this was a study that came earlier this year by Castro et al. It looked at about 20,000 primary care notes. And interestingly enough, the AI scribe visits capture more psychiatric symptoms, and yet it had lower odds are an actual intervention, either whether that was a referral, a diagnosis, or medications, which didn't really happen with a human scribe. So sometimes capturing something isn't necessarily the same as acting on it. And then richer notes sometimes can add to note bloat. So longer notes, and sometimes longer doesn't mean necessarily better. Now, a little bit more about equity, because there was a landmark study that tested 5 speech recognition systems and an error rate that was essentially doubled for Black speakers, and about 20% of the audio was basically unusable versus 2% for Caucasian speakers. Now, that was back in 2020. So since then, these tools have significantly improved. But there is the fair question. Is there an independent stratified validation for today's medical tools? And the answer is that we don't really have that right now. So what if the error rates is highest for the patients with the least power to notice or contest their own records? Are we automating documentation disparity? So this is why we need more information. And I think I see something on the chat, so let me pause for now.
Yeah, Dr. Magan, we can save them for Q&A, or if you'd like, I can go ahead and ask the questions now.
Yeah, I think why don't we leave it for Q&A since we still have a little bit of content to go through, but we'll come back to
Perfect.
that.
Yes,
Thank
we
you.
will. Thank you.
Okay, so let's continue to the next slide. So a lot of us have multilingual visits where you have the patient, you have maybe one or two family members, then maybe you have an interpreter in the room. And sometimes when there's so many people involved or there's noise in the background, maybe you're in a busy emergency room, sometimes the tool may get confused. So this is why it's really important that we assign roles or that we say out loud who is in the room so that the tool can catch it. And now that's why it's also really important to say, for instance, numbers out loud, because a 0.5 and a 5 in a really busy and noisy room might get confused. And also for telehealth, it's really important to also maybe you have a caregiver or the DPOA in the room. So that's why one, announcing the roles, two, narrating the exam, as I mentioned before. So maybe saying, oh, that was the left index finger, and then anchor every number. So saying it out loud. Now, the other thing that I found really helpful is that at the end of a complex visit, summarizing the whole encounter very briefly. So that way it can give a context to the tool so that it can build the note and make it a little bit easier and cleaner. And then we do need to budget some editing time because sometimes we need to go back and change things as we have talked about. Now, the consent, which is the biggest portion of this talk. And this is again for educational purposes. I am not a lawyer, but let's talk about it. So why AI scribes are not just a scribe in the room? Because the comparison can break in four places because sometimes the recording is not obvious. There could be a tool just recording in the background and the patient might not be aware of it. And then the audio, the recording goes outside of the clinic walls or the hospital walls. Now, the retention or how long that transcript is kept depends on the contract that was signed between your institution and the vendor. And a device recording triggers wiretapping laws that a person, a human scribe, never did. So this is why it's different. And this is the whole legal category. It's interception. And what do patients actually think when you ask them? There was a study by Shaw et al. That came out earlier this year, and they looked at 2,200 patients who had an AI visit. About 70% of them found the AI helpful, and about 73% said that we want to use it in a future visit. But the acceptance actually changed by age, gender, and race. And when you actually talk to them about storage and corporate access, the willingness dropped from 81% to about 55%. So this is why transparency and a full meaningful consent is really important as well. So what does meaningful consent include? So number one, including that is a recording that is going to record the visits. And then two, how this audio is going to be processed, how the audio is going to be stored, what's it kept, are there going to be any secondary training happening from this data? And then the note that is a draft and that we need to review it. They have the right to say no, and that is not going to change um, their their care. And then seven, that they can change their mind at any point. Now, what about consent in different states? So 34% or 34 states have one party consent. So only one party needs to agree to it. But then 16 other states require at least two people or all parties involved. Now, for telehealth, this is why it's really important to know where your patient is sitting and to use the strictest law. And California has one of the strictest law. So, next slide, please. So in California, we have the California Invasion of Privacy Act. It's part of the Penal Code 632. And basically, it means that it requires all party consent for confidential informations. And it can be pretty costly. So it's about $5,000 per violation. No proof of harm needed, and patients can sue directly. So if there are multiple instances when we're not where there's a mistake or where the consent was not done, then that can escalate and it can be very, very costly. That's why meaningful consent is really important. Next slide, please. Now, there are some cases that are starting in the state of California. There was one big class action that was filed against San Diego system late last year. And then in April of this year, there's another one against Sutter Health and Memorial Care. And there are 5 different claims. And all of these are still developing. So we don't exactly know what's going to happen, but it's happening all right now. And a consent workflow are being written all over the country. So the vendor the vendor has a business associate agreement, which is basically the contract between your institution and the vendor. And then we also have the HIPAA privacy laws, but that is not enough. So we need to have a very detailed, meaningful consent. And now a little bit more about the case. So there were 5 complaints. So the first one, the harm is the recording itself. 2, the real issue is where the audio is going, and that is going outside of a company or to an outside company, I mean. Then 3, the general privacy notice isn't a clear consent. So just by having a paper handout and not really going through it is not full consent. And then 4, the damages scale per encounter, right? As we mentioned, it was about $5,000 per violation. So the more patients, the more, if you don't give proper consent, then that can be very, very costly. So yes, BAA or a business associate agreement is really important, and also HIPAA, which are our privacy laws, are both really important. But you can still get a $5,000 SIPA violation without proper consent. And the other piece is that sometimes patients will agree to a tool or a scribe without fully understanding what they're agreeing to. So that's why it's really important to have those 7 pieces of the consent and to make sure that it's in their language, to make sure they understand it, and maybe even consider a little bit of teach back, especially for those folks that may have low health literacy, so that you know what they're agreeing to. Then there's the other piece of the shadow record problem. You have the audio, the transcript, the draft note, and then the sign note. And this pipeline can create some artifacts. So we also have the raw audio, the word by word transcript, which is an unreviewed draft, and then what happens to it? What happens if there is like a court case or if there's a custody battle, then what happens to that information? So what if someone is disclosing abuse? So something that I've done is that in my clinical practice, I actually pause for those situations. So, so the next slide, please. So a consent workflow that actually works. So in my clinical practice, it is important to, or some of the things that I found is that one is really important to notify early. Either have a written consent in the room in different languages that your population speaks. And then when you come into the room, it's important to actually go through the consent. Then document on the chart that they agreed or disagree or declined, and then honor the no. If they don't feel comfortable with the AI tool, then just let them know that is optional and it will not impact their patient care. And then for sensitive visits, or let's say that you're having a conversation and then someone discloses about immigration status or interpersonal violence, that's something where you can pause. So something that I say in my practice, so I have a written handout that I give to patients. Most of the time, they haven't actually had the chance to look at it or read it. So I go, um, so I talk to them and I let them know that I'm using this secure tool that a lot of other clinics and hospitals are using that is totally optional. And what it does is it records the conversation only for the notes so that I can pay a little bit more attention to them. It um, it is by X vendor and then it's held by for 30 days and then it deletes everything, is not being trained on your data. And it, like I mentioned, is totally optional. If there is anything that is sensitive, private, or confidential, we can pause it or not use it. And if that's okay with them, and they can always say no. So that's the gist of how I give my consent. And then most patients are like, about, I would say 80% of the time, they agree. Some of them have further questions, such as, are they using my data to train these models? Or some people just say, no, I'm not comfortable with it. And if they say no, then we just continue with the encounter. So when consent gets thin in the hardest visits, so this is where if you have a really busy clinical practice or you're a little bit behind, right? This is where we may skim. So one of the cases that also came out recently is by Cal Matters, reported that Kaiser's own mental health clinicians through their union raised concerns about the ambient AI scribe. And basically they were worried because it was recording the whole session. And this can resurface in a custody case, an immigration case, security clearance. And they said that consent felt coercive in both directions and that they couldn't really get a clear answer on where the audio even goes. Now, these were, the response was that the consent was obtained, that it was HIPAA compliant, and that recordings were kept at 14 days, and the data was not used to train those models. So here's where it's really important also to say, is it 14 days, is it 30 days, or does it get deleted as soon as you hit sign? So this is something that you can also ask when you're talking to a vendor. Next slide. So for my patients, I've started to pause, specifically for folks that are telling me about their immigration status, because that's something that does not need to be on the chart, right? It doesn't really impact patient care and it may have consequences later on. So I've started to pause, and you can also have a way to customize the tool so that you can not include that information on the draft. Um, and then the key is when it's mental health visits. So I think that that's where maybe a little bit more of a consent needs to happen. So what I've tell my patients is, I'm going to pause this tool so that we can speak freely. So a little bit of guidance and governance. What societies say and who is actually in charge. So next slide, please. So we have the American Medical Association that they are basically arguing that the liability, because currently the liability lands on the clinician that's signing the note and the health system. But the AMA argues that it should be a shared responsibility. So right now there's still, you know, oh, there's a comment. I'll come back to it. So this is the piece that there is disagreement, right? So I think that we're going to be, we don't have guidelines yet, but currently the liability lands on us. And next slide. What about regulation? Who's regulating the ambient AI scribe? And mostly no one right now. They are marketed, they're scribes, and they're not really FDA regulated. Documentation software sits outside the device definitions, and so none of them are cleared. So this is, again, why this is important, and consent is important. Now bringing it back to the equity lens. We care for about 31 million patients. A lot of them are multilingual, are socially medically complex, and that's where the burnout tends to be a little higher. And where tools can be really helpful, but it can also have the most risk when it comes to um, how the risk is spread. Because again, we learn about the differences in speech, hallucinations, and that's why when getting one of these tools, it's important to see if the training population or the training data set reflects patients that are like the ones we care for. And as mentioned, the majority of the studies are actually happening in big academic settings or integrative health systems, and not a lot in FQHCs, and in fact, zero. So what can you do? And some practical tips. 6 moves that can help with the risk. So 1, make sure that you have built a consent workflow that everyone in your institution knows about. What is the exact workflow? 2, having a safety officer, basically someone that is accountable for perhaps any logs or any hallucinations. Was it omission rate, misinterpretations? That way you can keep track on what happens in your actual patient population. And then audit the notes routinely, right? Make sure that we're reading it and proofreading it very carefully, and demand stratified vendor data. The data set looks similar to the patients that you're caring for in your clinic. And then what is the contract and data lifecycle? What happens to those audio transcripts? When do they get deleted? Can it be as soon as you hit sign, or is it something that it needs to be maybe 7 days, 15 days, 30 days? So what is that time, and how can you make it so that it's more helpful for you? And then pilot with equity metrics, right? With patients that speak different languages, or that they're code switching between 2 languages, or with a different interpreter in the room. What about if it's a noisy room and you're in the emergency room, right? All of these things you need to make sure that it's accurate for your setting. And 3 asks to leave with: consent, pause, and ask. So the consent, we spend a little bit of time about this and why it's important. It needs to be in the patient's language, and make sure that they understand what they're consenting to with all those 7 pieces. Now, I invite you to perhaps pause for those um, uh, encounters or those visits where there's a little bit more um, like difficult conversations. Maybe someone is having a mental health crisis, or are victims of domestic abuse or immigration. So some of those things you may not want to. You may want to pause and then just type what is clinically relevant, if any, and then ask. demand early deletion, no training use, make sure that all that information is written and that everyone in your organization is aware for proper consent. And if you remember 5 things, remember that the benefit is real, but it's modest and it's still early. I think there's still more data that is going to come and research studies. And the draft is not the record. Really, what counts and legally and clinically is what you sign. And the consent is a workflow, not just a form that you hand to patients. You need to check for understanding. And we have the strictest consent environment in the country. And equity must be measured, not just assumed. Okay, so I know that was a lot of content. So I'd like to pause and then see if anyone has any questions or comments. Would love to hear what you're experiencing in your own clinic or institution.
All right, Dr. Magan, we do have a couple of questions in the chat that I'll go ahead and read off for you, one by one, of course. So we had Anu in the chat ask, should AI notes be vetted before implementing? Choose more common visits and compare AI scribe notes versus provider notes to match closely before using it. Any thoughts based on your experience?
Yeah, I mean, I do think that that would be a great practice because maybe take 5 of your more common visits and then 5 of your more complex visit with multi-language or using an interpreter, and then you can cross-check and compare, like, if you had, if you're writing the note old-fashioned way or just like standard way versus using an ambient AI scribe, and then see are there a lot of errors or omissions or hallucinations? Because I think that would be helpful. Maybe this particular tool may not be as helpful as another one, right? And so it needs to be what's going to be best for you and your patient population.
Thank you for that. And another question in the chat is from Madi. Can you talk about the monitoring bias for hallucinations outside of the provider's review before signing? What is the org doing centrally versus contractual obligation by the vendor?
Those are great questions. And to be honest, I don't think anyone's really monitoring that yet, or there are no studies that I could find specifically about that. And again, the research and the data is still pretty early, but that would be something that maybe you can monitor internally in your organization as a quality improvement project.
Yeah, and to add to that, Dr. Magan, CTRC and some of the organizations that we do work with, we know that when providers notice some of the hallucinations, they're reporting it back to the implementing team so that that team can then communicate it as a whole to the vendor. So there are some of those internal processes built into AI scribe usage, similar to what you said, Dr. Magan, but it probably is wise to build that in as part of your workflow as well.
Yeah, and I wonder something that may be great is if we have several different organizations that are doing these similar projects, maybe we can find a pattern, right? Maybe it's a very specific area that is making mistakes or omissions, and then the vendor needs to fix it or maybe find a different way to optimize their model.
Yeah, thank you so much. Let's see here. We have Lisa. Do you read the consent in its entirety for each patient encounter, whether an established patient and or unique encounter, or just a summary of your consent?
Good question. So what I do in my practice is the very first time that I meet a patient, I give them the written consent and then I go through my spiel, which takes about a minute. And then I ask if they agree or not, that either way is not going to impact their care. And then the next time I see them, then I go through a more abbreviated consent. And then I ask if they remember and they're like, oh yeah, the tool that records things. And they're like, okay, great. But if they still have questions, then I go through the consent one more time because again, it's important that they understand what they're consenting to.
Thank you. Another question is, how does a provider's organization approach the question of, does the patient have a right to access the transcript/recording?
Good question. Yeah, my understanding is that the actual transcript, the actual recording goes to the vendor, hence it gets stored in the cloud. So that's something that you can negotiate when you sign for the business, the BAA, the Business Associate Agreement. Now, how to negotiate that and how long that stays, I think that's something that your institution needs to coordinate with the vendor because it may vary, right, institution by institution.
Thank you. And another question is, if it's not relevant to the visit, how often do you ask about immigration status?
I don't, but sometimes it's come up. For instance, like they are having stress or anxiety, and then I ask them like, "Oh, what happened?" And then, they share their story and how hard it's been. So when they start telling me about that, since it's not necessarily clinical relevant, then I will pause it. Or if it's, for instance, like domestic violence or interpartner violence, then I will pause it and just type some of the things that are clinically relevant, right? Because in that case, we do need to document some things, but maybe we don't need to document everything, right?
Yeah, good point. And then we have another question asked similarly, can a patient ask for copies of the ambient recordings and transcriptions?
Good question. Again, I think that that's based on the BAA and what you signed up for. And maybe that could be a clause that maybe if patients want to get a copy of the recordings that they're allowed to, but then that has to be a specific workflow that has been put on the contract.
Thank you. And Dr. McGon, I'll switch that
Mhm.
question just a little bit. Have you had an instance in which a patient asked for those recordings yet?
Not yet, but I have had patients ask me, like, is this being trained or are they using the recording to train the model? And the answer is usually no, but you need to check again with the own contract that you
Mhm.
signed for your organization.
Thank you. And before the provider signs off on a progress note, are the recordings considered transient artifacts?
Transient in the sense that they're not being used, or what do you mean?
Is Leonard Kwong able to unmute and clarify the question?
Yes. So my question is, I guess when a recording or a transcript is used and before it's actually, I guess, summarized or used in note, are they considered like transient? Like, I guess if you were in the past, I guess, documenting and you're just jotting down notes or so. But that doesn't necessarily make it into the progress notes. That's considered like transient, or like when you take a sample and it becomes maybe unusable or so, that something like that would be transient. So I'm wondering for these recording and these transcript before it actually make it finalized in the progress note, are they considered transient? That would answer a lot of questions on if these things need to be kept or archived or so. But I do understand that, most systems they keep them within a certain period and it just gets auto deleted or so. But in a case where a patient may ask if they can have copies of it, I'm wondering, are we required to really provide those, or it's just the notes that were finalized and signed off?
Good question. So my understanding is that they are transient in the sense that they don't count clinically or legally. So once you review it and then you sign it, then that is the legal record, and that's what we're liable for. Now, if a patient can ask for their own transcript, that I'm not entirely sure. That hasn't happened yet, but I think that this is why having conversations like these are important because why shouldn't they be allowed to have access to that information, right? We have open
Understand.
notes, like why not the open transcript too, right?
Thank you. Thanks, Leonard, for
Thank
unmuting
you.
and participating in that conversation. Okay, we have another question. Do you feel that the steps you're taking to make the ambient scribe work, like summarizing, pausing, listening, changes the nature of your interaction? Does it flow into your existing process, or do you feel it's clunky? How long did it take you to internalize these ideas?
Good question. So I actually started using these tools when I was still in training. So I started using it during my last year in residency, and that was really helpful because then that's when I started really learning about consent and what is a meaningful consent. And so now that I've been using it for a while now, it's become part of my standard practice. So I usually give them the consent, go through my spiel, and then start the visit. And what I found personally is that I really enjoy having the time to be able to look at patients in the eye. And then I do a lot more health teaching and like health literacy that I did before. So I'm able to pull up pictures and go through, oh, this is the heart, and this is what's happening when you have an arrhythmia or AFib, or just different things. So it allows me to do a lot more education than in the past. And I've had some patients tell me like, oh wow, like I really like that you're spending so much time, and now I really understand this. Um, but again, this is something that I found, and we talked about all the different caveats of why consent is important, and then also honor when patients don't want to use it, right, for privacy concerns.
Thank you. And Fran asked, retentions of recordings is 7 years for telehealth in California. If part of the legal medical record, why would we expect the time frame to be any different for AI?
I think because it's a different tool and it's still developing, and we're using it not just in telehealth, but we're using it in-person encounters, and the law is still getting developed, right? Like those guardrails and how long we keep this information. So that may still vary, and with the lawsuits, things may change, right?
All right. The rest are comments in the chat. So if there are questions for Dr. Magan, we can unmute and ask the questions directly, or if there are additional questions, they can be dropped in the chat. There you go. One just popped up. What happens to the recording/transcript if the patient revokes consent in the middle of a visit? What's the provider's workflow? Does that verbal revoke get documented or tagged somehow?
So I think the moment that you stop, then that stops the recording, right? So there's nothing else that continues, and then you can continue with your notes the old-fashioned way. And then, at least in our workflow, what we have, it's a button that says patient does not consent, and then usually that will get deleted. But that's a good point. I don't know exactly if there's a specific way that we can tag that file, that note saying like, please delete the voice recording as well.
Thank you. That's a good topic to discuss. Thank you for asking that question, Mari. And another question got dropped in the chat. How are you describing to the patient the technology being used to capture the recording? Is it a mobile device, dedicated hardware, an embedded room-based system? How do you describe that to the patient?
Yeah, I usually say that I'm using a secure note-taking tool or app. And it kind of varies if they're a little bit older patient versus a younger patient. I say app because they usually understand it really well. And if it's an older patient, I would say it's a tool. And they usually have the handout with them that says AI. I just say secure note-taking tool because sometimes if they hear AI, they get a little bit closed off, but then I just explain what it does and the purpose, kind of what we've talked about. And then most of the time they say, sure, yeah. And then other times they're like, no, I just don't trust AI. I'm like, okay, no problem. And then I just start typing.
Mm-hmm. Okay, I'll give it, that was the last of what was in the chat. I'll give it just a little bit more. We do have 2 additional guests that will be joining us in just a second from TTAC. So if there are more technical questions, we do have them available to answer them. But if, oh yeah.
Oh, hi. Sorry. I actually just dropped a question. My name is Jessica. I was just wondering, even after like a signed process is consented for that patient, do you still recommend verbally consenting with every appointment
Yes.
by the provider? Okay.
Yeah, so I do it every time, every visit. And if it's someone that you've seen in multiple times and you've already done the consent is going to be a lot shorter because like, oh yeah, the tool that you used to record, and they're like, yeah. So it just gets shorter the more comfortable they are with the tool.
Got it. Thank you.
And it does look like we got another question in the chat as well. What questions will you use as a provider? Do you want to ask when the AI ambient documentation tool comes out with a new feature suggesting diagnosis or treatment recommendations?
Yeah, great question. So now, depending on the vendor, right? Like there are some vendors that are turning it more into like a clinical decision tool where you can pull, for instance, up-to-date AI. And then you can also prompt it to customize it to, like, for instance, like the way I've customized it is number one, I don't include any immigration status. Number two, I actually like to say when my orders, medications, if I add something new or if I'm stopping a medication. So I've prompted in a way that actually helps me to have things very clear. That way I don't miss anything because if it's just a block of text, it's going to be easier to miss something. Does that answer your question? Oh, and the other thing I forgot to mention is that when for instance, if someone is having an undifferentiated problem like abdominal pain, in order for the AI to really capture the different or the differentials, I would say them out loud. Like, oh, I think this is not pyelonephritis because XYZ. I don't think this is an ovarian cyst because XYZ. So I would say that out loud to the patient as I'm letting them know what I think is most likely. And so that way the AI will capture that information.
Thank you. A couple comments. Outstanding presentation, Dr. Magan. Lots of ethical questions to be explored too. What are some of the forums you are participating in and would recommend others to join?
Forums as in like other talks? Well, CTRC, definitely, they have great information.
Do you subscribe to any newsletters? Like, are there forums where other providers could potentially join or subscribe to so that they can get regular updates and be able to participate in these types of discussions?
Not that I have found, but yes, AI Med, or, the American Board of AI in Medicine, they talk about different things regarding AI and medicine. I also selfish shout out. I have my Substack where I write a lot about these things. There are other podcasts. The AMA also has some curriculum about AI and ambient AI scribes. The AAFP also has a little bit of information about scribes as well.
And Dr. Magan, I will double down on your shout out. I do read Dr. Magan's Substack. It is very helpful in understanding, no, very honestly, the concerns and issues that come up that you wouldn't think of generally, that she shares, firsthand experience with almost, it seems like on a day-to-day basis, Dr. Magan, because you post regularly, but yeah, it's really helpful, even from our perspective, is understanding how to best support our providers in California. So that is a great shout out. All right, so we're gonna just move on into some administrative stuff, but we will still open up the floor for questions. So before we wrap up, we'd like to invite everyone to complete a short survey. We want to ensure that we're meeting your needs and feedback directly your feedback directly informs the types of programming tools and resources that we develop at CTRC moving forward. So we're going to drop that in the chat if you can take a minute. But I'm going to move on to ongoing support. For ongoing support, make sure to check out our website at keltrc.org, where you can find events, webinars, and on-demand resources, and so much more. You can also email us directly at keltrc@ochin.org. And we encourage you to stay connected as we are now transition into our office hours where you can continue to ask your questions. We encourage you to stay connected with the CTRC for upcoming AI cohort sessions, resources, event updates. This session is being recorded and will also be provided for you to share with colleagues. You can follow us on social media and visit our AI cohort webpage to access materials and learn about all of our future sessions. And the link is going to be in the chat. So now we are going to move over to office hours. So I'm going to introduce two folks who are on the call. I see we have Jordan Berg, who is Director and PI for the National Telehealth Technology Assessment Resource Center, a partner of CTRC's. And then we also have Kelvin Ross, who's a technical specialist, also part of TTAC. So if there are additional questions, I will take a look. I don't see any questions, but again, Dr. Magan, just thanking everyone for her time, or everyone's thanking her for her time and her experience. It's a great discussion, and it's very helpful to get her firsthand insights. Any questions for Jordan or Calvin? I see some folks are typing in the chat, so I'm going to give it just a minute or two. It looks like the question came directly to me, but it is a very good question, I think, for Kelvin or Jordan. On a technical side of the house for AI Scribes, when you're looking to implement at an organization, what time frame should you allot from vendor vetting, governance to implementation? So how much time would you recommend in exploring AI Scribe implementation?
Like all great answers, it depends. A lot of this is going to be based on kind of what you're trying to implement, and then to be honest, we never have the time that we want. You'll be most of the time there is an external factor that's pushing these things forward. So to sidestep the question, what I would recommend is front loading your time as much as possible. So focusing in on use case, focusing in on governance, focusing in on getting the right stakeholders to the table, and really having a thorough plan for what you want to accomplish before you even begin kind of engaging with vendors. And then seeking out some other organizations that are like similar to you so that you can begin kind of asking them. But it's definitely not something I would want to do in a month. It's more something I want to do in 2 months on the minimum. You want a nice ability to go in, take a look at these things, go to vendors, follow up with vendors, and then revisit questions and really kind of dig, because what you're going to find is the first couple of conversations you have with vendors is everything works, everything is perfect all the time. But then as you begin to peel back the layers and ask really specific use case questions, things get a lot more complicated and the details start to matter a lot more.
Yeah, excellent point. With that, the follow-up question from the same attendee is asking, what teams from the org should we pull in to help assess whether an AI scribe tool works for us?
I'm going to kick that one to Calvin. I think, go ahead, Calvin.
Yeah, so I mean, the AI tools are complex and they reach across multiple levels of your organization. The biggest thing that you can do is make sure that you have a representative from every respective branch of the organization, that you have all the appropriate voices at the table. That can include leadership, that can include governance, compliance, IT, providers, administrative staff, and even patient feedback at some level as you're considering what tool to implement and how it's going to be used across your organization. So making sure that you have all the appropriate stakeholders at the table. And I did link our Tech 101 guide within the text or within the chat here for folks to review after. And it does really kind of go over what stakeholders you need at the table when you're doing a technology assessment. And there again, like, these tools can be applied to AI, but they can also be applied to any new technology that you're trying to implement within your organization. Yeah.
And to follow up on that, I think we're all really aware there's so many technology changes that are happening, and the space is changing rapidly. So building that group beforehand and knowing who that group is, that lets you use that team over and over and over again and have that team build some rapport so that they're able to kind of engage with these things as they come up quickly, rather than trying to ad hoc pull together people because someone's going to be left out. So having, and you can call it whatever you want, like a technology implementation committee or an assessment team, or but having a core team of people who, like, this is part of their duties and responsibilities, and that they know each other and have relationship, that really will smooth out. You don't have to build that from scratch every single time. So that's one of the things that we highly recommend. It's going to work for AI. It's going to work for medical hardware selection. It's going to work for a lot of the EHR questions that you have. So that it's really a key. Build your dream team, and then you can reuse them for a lot of these queries.
That also gives people within your organization a means of communication when they have new ideas or when they encounter new tools. It can be kind of your first line of defense of, like, this tool, we've looked at it, we've done an initial check, we're not ready to consider implementation, or we've done an initial check and we put this in maybe our pending bucket when we have funding. You know what I mean? It kind of provides a advisory panel that can do that initial vetting before you do the full implementation process.
Yeah, great points. I also think that established governance committee, in whatever sense that looks like, does help so much when things go sideways after implementation. Because then you have that core group of folks who are already familiar with the technology. They were part of that vetting process. They were part of that implementation process. So if there's any, compromise to the data, or there's, something that needs review very quickly, you already have that group of folks that are familiar with the vendor or the tool that's being utilized. So great points all around. Let's see, Fran asked, or is stating and then asking, I'm considering moving to edge computing, an isolated workstation, instead of a data center for AI-enabled scribing. What are your thoughts? Will it help address hallucination and other issues that are experienced with these tools?
That's a really good question, and I think we're going to see there's been a trend to move away from the cloud, and that this is kind of addressing that trend. Is that there was For a while there, it was like, yes, we want to move everything off-prem because it's easier to manage through cloud-based systems. But we've also just realized in the last, or from like kind of an IT perspective, there's been a move back to owning your own hardware, owning your own systems. What you have to realize is that you're just kind of moving the risk around. And if you have a cloud-based vendor and you have a well-vetted cloud-based vendor, that reduces a lot of the complexity, and make sure that, hopefully that they should be doing updates, they should be doing compliance. If you own this data, it's sitting on your servers, and this information now belongs to you, that's covered under your risk, not necessarily the risk that you're addressing in the BAA. So yes, these tools can be helpful. They can be a lot more limited in scope. They can also be tailored for your patient population a lot more accurately. But the challenges that you have is if you're going to get these tools to work well, you're probably going to need to be training them on your data. And all of a sudden, most of the vendors that are putting out these tools are not training it on patient data in the moment. They're building their training system and then they're deploying it. So if you're going to kind of iterate on these tools, you're going to have to really start address some of the concerns that a lot of that is being handled at the vendor level. So it potentially has the benefit of being quicker. It tends to have the benefit of being a little bit less broad. So the more broad we get with generative AI, the more likely we have hallucination. But at the same time, the fact that you own the data, the fact that it is all happening within your system, there's some additional risks there that you should be aware of.
And the AI models have to come from somewhere. So they still have to come from a vendor to start with. Or are you planning on building it all from scratch? If you're building it all from scratch, then of course you're going to need your own hardware to create a tool that's beneficial. Where we've seen people using edge computing is really in kind of the bleeding edge of the AI space, in which they are developing their own tools internally for advanced clinical decision tools or something like that, or population studies. But we haven't, oftentimes it's easier to, you're still using a vendor no matter what. Yeah. And if it is your tool, then you have to think about, the retrain cycle and upkeep and maintenance and all that sort of stuff, versus if it's a vendor, then they just disclose it and you hold them accountable.
Great discussion. There was one question that came in, again, privately, directly to me, asking, does the adoption rate of AI scribes surprise you? And the question is asking through a lens of you both supporting technology over a long period of time.
I'll take a stab at this. Calvin can follow up. I am surprised, actually. We've had a lot of discussions with a lot of organizations, and there are some surprisingly rural FQHCs and other organizations. And maybe I'll throw this one back to you too, Amelia. I think you've been seeing this potentially as well, but I'm surprised at the rurality that we're seeing with some of these AI tools. People are, yeah, of course we're using ambient documentation because, I think some of that is because some of these tools are bundled into EHRs and other applications that they're already using. So it's a matter of kind of bolting on a process to something that they've already done. But I am surprised. I'm always kind of surprised when we go and we meet with a really pretty rural audience and we ask, how many of you are using these tools? We get a lot of folks that are actually using these tools and kind of engaging with them.
Yeah, I agree with that. I think for the early part of my career in healthcare, the big struggle was many orgs moving over to an EMR and how long that took. is moving from anything really technology centered. So kind of comparing that to now and how quickly it seems like everyone is adopting AI, particularly AI scribes for documentation. I also was part of teams that rolled out even speech dictation, and that took a long time and evolved over time within the org that I worked for. It was a 2-year project, and even after that, there were many physicians who didn't adopt speech dictation. So the fact that they so quickly jumped on AI documentate or scribe documentation, it is very surprising to me. But I think it's very indicative of the world that we live in now versus the one we lived in previously, where just so technology just drives so much, and there's 100 devices in my phone alone compared to before as well. So yeah, surprising, but uh, I think that's why we have so many of these discussions, is because we're all just trying to orient in a very quickly changing landscape. A little bit unprecedented in my mind.
I'm sorry, I'm not sure if my message is going through, so I'm just ask a question through this. I'm wondering, in lieu of this quick adoption that you guys are seeing, what are some potential pitfalls or blind spots that you would want to call out?
I don't know that I could address this any better than the speaker did. I think she actually outlined really a lot of the key things that I would mention. I think a lot of, not all these tools are created equal, and these tools are changing. So it's really on the providers to be vigilant. So a tool that's working today could get an update, and all of a sudden it's not doing things the way we would expect it to do it yesterday. I also think that as humans and people, we really like when things are easy. And so this confirmation or this automation bias is really something that we have to be looking at. Is just because it's there and it looks pretty doesn't mean it's right. And I think we have to be really diligent in looking through these notes, and assessing whether or not this is actually what actually happened in the visit that we just had, and not just kind of rubber stamping. And I think the other element that was really brought up that was really kind of key is the math for a lot of this changes depending on patient population. We're not addressing our patient population, and we're not looking for errors that are cropping up because of the different types of patients that we treat. That's a really big blind spot. Again, these LLMs live and die on the size of the data sets that they're built on. And in order to have these really large data sets, they're kind of an average of a lot of the population. So if we're serving, for us from TTAC, we are a tribal health organization, our parent organization. So our Alaska Native population, the needs and the way that people speak and all this is very, very different than the rest of the United States. And I think all of us have populations that we serve that are like that. And we want to make sure that the tools that we use are tools that are going to work for everyone. And then I think the other big thing is patients need to know really what are they getting, what's happening with their information, how do they have a voice in like being able to say, yep, nope, I don't want to do this, I don't like it, and that being okay. I think maybe one thing that did get mentioned that that was mentioned, but I think the speaker just had it kind of ingrained, is there's a lot of work that needs to be done to get providers comfortable having these conversations with patients and really being able to do this. I think being able to explain technology in a way that's not going to frighten our patients, that's going to point out the benefits, but also the risks, and make sure that patients are equipped. I think that's a huge skill set. That's an important skill set. And I think we have a lot of work to do to make sure providers are up and ready to do that.
Yeah, that's a great point, Jordan. And Jessica, to add to your question, Dr. Magan on her LinkedIn and on her Substack does dive deep into those instances where her scribe just doesn't work for her based on the patient that she's seeing. A lot of that can go into what Jordan mentioned. It's just a patient with that is using terminology that is very unique to them culturally or ethnically. And then also accents is also something that AI scribes, based on what I've read Dr. Magan write about, and she's no longer on the call, so I'm doing my best to speak for her, that she has pointed out that that can be a blind spot for scribes, depending on the accent, depending on how thick or not as thick of an accent, that can really influence the accuracy of your AI scribe. But she does a phenomenal job exploring each of those use cases and exploring what she did to work around them.
Thank you. Thanks for answering.
Mhm. All right, so we have one more question, probably all we have time for in the last few minutes, but Anu asked, what is the accountability for AI being implemented? It has to be ongoing and needs regular oversight. What are your recommendations that include privacy, security, and also relevant information being captured using AI?
Again, I think this was that this was talked about by Dr. Magan a little. The way that this is falling out right now is there's so much accountability that's being housed with the provider. A lot of these tools aren't medical devices. They're not software as a medical device. So it's really incumbent on the provider to verify that what's happening with these tools is medically accurate, is really having good patient outcomes. So it really is the provider that's responsible for that at this point. There is kind of movement to hold the people that build and train these systems more accountable for the outcomes from the systems. But right now, really the accountability lives with the provider on a care by care basis, that you are responsible for the content of your note. When you sign it, you're kind of making that part of that patient's medical record, and it's up to the provider to make sure that that medical record is accurate based on the encounter that they just had.
Thanks so much for that, Jordan. Completely agree with your comments. With that, I wanted to thank everyone for attending today's AI cohort session. It was a really great and timely conversation for all of us to sort of work through our questions and get some really helpful firsthand information from Dr. Magan. Thank you to our speakers from TTAC, Jordan and Kelvin, for participating in office hours. Again, on the CTRC website, we do have access to some really helpful AI resources. We have a consent guide. There's a governance toolkit in there as well. And as always, CTRC is here to help as needed. So reach out if there's any additional questions. But again, thank you all for your time and participation today. We hope to see you next time. Thanks all.